Hi, Ryan. Thanks for joining us today. Um, if you don't mind, can you please introduce yourself to this audience and tell us about your initial condition? What were your priorities at that time?
Of course, sure. I'm Ryan Creech. I'm a 40-year-old male from Kentucky. I was injured in an ATV accident back in May of 2007. I graduated with my bachelor's degree 16 days before my accident. My ex-stepdad came to my graduation and we got to catch up for the first time in years. And he invited me to North Carolina to visit with him and his 3-year-old son. So I took a Greyhound bus and went to go meet them. We decided the next morning we were going to go ride ATVs, four-wheelers, which was something I'd never done before. And it turned out I wasn't very good at it. I ended up airborne. The ATV bounced on top of me a couple of times. I ended up with a broken sternum. I had cuts all over my face and head, some internal bleeding and spleen stuff. And I broke my spinal cord around T3 or T4, so like the middle of my chest. I wrestled around on the ground for about 10 minutes, like trying to will myself to be able to get up so I didn't have to go to the hospital. The local hospital sent me to the trauma center by helicopter, and I finally got a spinal fusion. I was diagnosed as a T6, T7, Asia C incomplete, paraplegic. Had some hardware put in between T3 and T5 to stabilize everything. And immediately after, I had some more feeling in my left leg than my right. And that was kind of my new reality to grow into. After I got hurt, I moved back in with my parents, having lived through college all by myself. And it took a lot of like back and forth and butting heads. But yeah, I mean, at that time, I was just focused on survival and on kind of like my biggest priority was just learning to understand my new body and what life was going to be like going forward.
I see. Thank you so much for sharing. And I know it's a lot of personal information, and we appreciate you sharing all of that with us. And it's amazing how initially after injury, you mentioned the word survival, how fundamental our priorities are. So I wanted to ask you a follow-up question. How did your priorities evolve over time? I mean, looking back at that injury at that time to looking at yourself right now, do you see a shift in your priorities over this course of time?
Yeah, of course. Yeah, so I spent right after I got hurt, I spent about 6 weeks as an inpatient at the Drake Center in Cincinnati. Um, I saw lots of other people. I had roommates and people in therapy groups, and I tried to learn everything that I could about them and about myself and where my functional abilities were. When I came out of my initial surgery, I didn't have like a tortoiseshell or brace of any kind, which was good, but they also didn't do anything to fix my sternum. So where my sternum had broken, the two sides were just kind of rubbing against each other all the time. And it made it super painful and tough to learn to use my arms to get around. So, I mean, that was the kind of thing that was on my mind when I was inpatient. Um, as we both have said, survival, right? So when I transitioned home, I was lucky enough. I had good support from the community. We had a really close family friend who was a machinist. He pulled out some diamond plate steel and welded us some ramps and things to make our kind of rental house that we lived in accessible. And then I kept doing outpatient rehab for almost a year. At the very beginning, like what I wanted more than anything was to be able to just get back to my normal life where I had been to school in Kentucky and I had a girlfriend there and friends there. But I was stuck in Ohio for almost a year just to do the rehab. It was really humbling for me because suddenly there were so many things that I couldn't do. Overnight, I went from being like an independent young guy who could do stuff on my own, just kind of living my best life, to like not being able to wipe my own butt, you know? And so it was such a shock for me. So, I mean, my priorities certainly evolved in that, like, I went from that initial survival thing to now I need to figure out how to get my life back on track.
Thank you.
Right. Ryan, once again, thank you so much for coming and sharing with us today. You've spoken about survival. You've spoken about, several transitions from the acute hospital to the rehab hospital to home, and how your priorities over time shifted as you moved through this very difficult process at the time of trying to adapt to everything that's going on. Could you share with us a little bit about how you felt your priorities and the priorities of the teams that were providing you care, doctors, nurses, therapists, changed, and whether or not those were in sync or out of sync? And if you wouldn't mind maybe focusing a little bit on some of the cardiovascular issues that may have occurred for you at that time, like orthostasis or autonomic dysfunction or autonomic dysreflexia.
Early on, I was still getting used to like the reality and using my new body. So, like I said, I didn't have to wear a shell or a stabilizing brace after I got hurt, but I did wear an abdominal binder for months, like I think 6 or 8 months after my injury. It helped keep all my dressing in place while I was healing up, and also helped me avoid orthostatic hypotension things while I was in the therapy gym. Um, where I was sitting all the time and like my legs dangling, it was definitely a concern, like it is for all new spinal cord injuries. So the ab binder and some compression socks really helped with that. I did kind of get into the autonomic dysreflexia stuff early on, especially triggered by problems with bladder and bowel. It took some time to get all the medications and like, the management programs and stuff in place for that. And so the cardiovascular things were there, and they were kind of part of like what was making life so hard for me and like mentally so hard for me around the disability at that time. But yeah, eventually, as I got more stabilized, those things kind of were minimized by me being better able to care for myself.
Thank you. Oftentimes, once patients progress from being in the inpatient rehab setting or even in the acute hospitalization and they go home for the first time, it can be very scary, it can be very new, and there's often a big transition that takes place then. I know you've talked some a little bit about looking things up and family friends stepping in and helping out, but can you tell us a little bit about outside of the formal healthcare setting, what were kind of some of the things that you and your family had to do to support your recovery, and how did that impact you guys?
Yeah. So, kind of one of the most important things that I learned then and, since then as an advocate and someone living with a disability is how important that community support is. During my first inpatient stay, like I know we talked about some of the cardio issues around spinal cord injury. I don't know if we didn't go into that in enough detail or if I just had way too much going on at the time, like get used to absorb it. But I left the rehab hospital at least without like a functional, like usable understanding of what that stuff was. As part of my outpatient therapy, though, I started attending like group therapy sessions. Drake Center at the time was great about they had like a weekly group session, and they would bring in other people with spinal cord injuries and other kinds of disabilities who had lived with those for a while to sort of talk to us newbies about what kinds of things that we could expect and what it looked like down the road. At the time, like I had never really met anyone with a spinal cord injury. Like I had nobody in my family that I could talk to. I really didn't even know anyone who was a wheelchair user. So in those group therapy sessions, I got to hear from real people, and a lot of them shared their experiences with things like autonomic dysreflexia or hypotension. And this is where I really picked up on like this is what you watch for, this is how to recognize symptoms, and these are kind of what the long-term effects can be if you don't take care of these things.
It sounds like those peer supports that you had were often maybe a little bit even more so educational than your time with the doctors and nurses and therapists at times.
For sure, yeah. There's something about having that like relationship, where you're building like that friendship dynamic and really kind of getting it across to each other that way.
Very important, very important. If we can focus a little bit more specifically in on some of the cardiovascular issues that you have faced, like autonomic dysreflexia or on orthostatic hypotension, how did that impact your rehabilitation, both in the, acute to subacute period when you were in, the rehab setting, and then long term?
Yeah, yeah. Well, as things went on, one of the kind of big highlights, I guess, of my recovery is I did get fitted with a set of KAFOs, like long leg braces, so I could work on standing. I spent almost 9 months in physical therapy working to use those to be able to stand up and walk around safely with the leg braces and a walker. That included a few weeks at Cardinal Hill Rehab Hospital in Lexington, doing like a phase 3 to really focus on the long leg braces. I got married in 2011, 4 years after I got injured, and it was really important to me that I be able to stand up for my wedding. So, like, I really kind of pushed myself and went through that. But with that, like, the physical therapy for that was just so challenging. And we started off with like a bone density scan because it had been 4 years, just to make sure that I was able to stand up and put weight on my legs. And then after that, like, orthostatic hypotension was the biggest part of my recovery. Like, that was what we really focused on during those sessions. So, as soon as I got there, we would start taking blood pressures, and we would take them like every few minutes as I was transitioning to standing and things. Again, wore the compression socks, and I think I even wore the abdominal binder some, just to kind of try to keep things regulated. We started off those sessions on like a tilt table, and then eventually moved up to a standing frame, and then to the leg braces and a walker. And it was tough. And I mean, there were definitely times that my BP would drop, or there were even a couple of times where it like went up really high because we would have like the equipment pinched somewhere or something. So being able to monitor for those cardio events really helped a lot with the PT side of it. We would take breaks if my BP started to drop because of the standing, but because it was so important to me, we really focused on building up that standing tolerance so that I could be upright for as long as possible. A few years later, I ended up with a standing wheelchair, and it was kind of the same thing. I had to sort of like build up that standing tolerance again so that I didn't drop with that orthostatic every single time that I did. And then, like, as I've gotten older, I've started having more problems with things like my bladder and bowels, especially my bowels. They just don't move as well as they used to. It happens to all of us as we get old, but it beats the alternative. After years of being pretty regular with that stuff and like kind of keyed into my body signals, I never really had a structured bowel management program. But I started seeing signs of trouble. So just in the past few months, I'm having to kind of get myself to do something that's more regular and more structured. But I still end up with like constipation, or I'll have really urgent needs. And around those, I still experience the autonomic dysreflexia. So I would say 4 to 5 times a year, like maybe quarterly, I still will end up in full-on dysreflexia due to bowel impairments or impactions or whatever. But with the years of experience I have, I'm very thankful that I understand what it is and what to watch for, and I can be ready to address it when it happens.
So, Ryan, just a follow-up question on that. It looks like as you navigated over the years with your recovery, you created a great network, great peer support. You educated yourself over time, and looks like you tried a lot of different technology. And being a tech-savvy person that you are, uh, was there any other medication, any other technology that you feel is present today that would have helped you back in the days? Is there anything that you think you would have tried earlier?
Yeah, for me, it wasn't so much medication or technology. It was kind of the educational part of it. Like I said, I'm kind of learning about my own body and like what my physiological responses look like, was a big thing. Understanding the symptoms and what they mean so that I can kind of get on top of it early. Like now when I have something that feels like autonomic dysreflexia, I can go through the systems, like the body systems that I know contribute to that, and especially that contribute to that for me, and start looking for things. Like I said, for me, it's almost always bowel related. And then I can focus on like using suppositories or digital stimulation or whatever to kind of solve the problem and get to feeling better. But I feel like a lot of that, there was just so much kind of thrown at us during the acute phase in the hospital that it didn't absorb as well. And so I think kind of the like experiential learning as I've gone through and had to actually experience those things in real life has contributed a lot.
Once again, thank you, Ryan, for coming and sharing your experience with us and helping to shed some light on an issue that's often underappreciated in this population. Kind of finally to wrap things up, from your perspective, are there things that you would recommend or advise for healthcare providers to do and recognize as it comes to treating people with spinal cord injury, maybe specifically focusing on some of those cardiovascular issues that we've discussed throughout the presentation?
Yeah. Okay. I do feel like I learn more, like as far as from clinicians. I think that kind of those secondary, like, phase 2, phase 3 visits that I had at Cardinal Hill, and that, like my visits to UK with my PM&R staff, I feel like I learned a lot more there than I learned in that acute stage where I was in the hospital. So, again, like during that phase 1, there's just so much coming at you, and that's not really where your brain is. At the same time, like they would talk to us a lot about like reproductive health, and they talk to us about kind of long-term other health effects and mental health, and like it's hard to focus on that stuff when like life is just falling down around you. So I think for me, the most meaningful experiences came outside of acute and from other people with spinal cord injury. Um, Clinicians try really hard to empathize and understand where their patients are coming from, but for the most part, they don't. I mean, it's hard to actually put yourself in that same position. Um, I was also like I was a lot more open to learning about that stuff and a lot more curious about it once I had experienced autonomic dysreflexia and experienced orthostatic hypertension. So, kind of like hearing about those things in the hospital, they seem abstract. As a T6, I'm like right at the level of will he, won't he have autonomic dysreflexia? And so like it wasn't something that I was dealing with every day when I was inpatient and things. And so for me, it wasn't as big of a concern because I hadn't had it before. Like I was learning about it. Well, this is never going to happen to me, that kind of thing. But because I did absorb so much from like more of the community people and the support groups and the others with lived experience, it's always been a big priority for me to attend like group therapy sessions and support group sessions whenever I'm asked. I've also I was one of the founding members of the Kentucky Congress on Spinal Cord Injury, which does a lot of advocacy work and things. But the biggest thing that we did in the early days was kind of build that community. And so, we use it as a mentorship program kind of thing, and connecting the young folks and the more experienced folks. I've been involved in several different mentoring programs that have kind of, come up and fallen apart over the years. Being able to connect one-on-one and kind of share those experiences, especially when you meet someone or a family who doesn't have a frame of reference for that. I think that's the best kind of environment to hear about this stuff and learn about it as a patient. In clinic, I think it's super important to be a good communicator, like use plain language, use examples and case studies. Like don't just toss out, medical jargon and stuff. Like, I mean, just kind of try to personalize it for the person you're talking to. I've always been a little bit more health literate, but like I know a lot of people who aren't. And so, kind of trying to get rid of the confusion is important. Keep nagging your patients though, like, because we might not be ready to hear it at the end of that acute phase, but like, we will eventually. And it's so important to understand. And so, like, bug folks all the time. If you have someone who comes into clinic and they were talking about a time recently that they felt like garbage at home, kind of talk through it with them and see, like, can we attribute that to something? Like, okay, so it went away after a while, but like, what did you do to treat it, and that kind of stuff. Really kind of try to meet them where they are.
Thank you. That was awesome.
Yeah,
Great
I
job.
think it's a great session.
Yeah, well done. Thank you.
Great. I appreciate you guys having me.